Hello everyone and welcome to our last and final video for abnormal psychology. So this is the last part of our video lecture series and we are going to discuss neurodevelopmental disorder. So I hope that everything is well and fine on your end and you're still enjoying our video series, and hopefully you have learned a lot over the past term about abnormal psychology. So without further ado, this is Module 6, Part 3. So without further ado, let's go on with the video. The first part of our lecture will be all about intellectual disabilities, and in the DSM-5, it's actually divided into, I think, 5 major disorder groups. So if you look into neurodevelopmental disorders, so there is the intellectual disability group. There is also the communication disorders. There are also the autism spectrum disorders, the ADHD disorder, and of course, specific learning disorders and motor disorders. So there are 5 major groups, disorder groups within the neurodevelopmental disorder group. So, but I will only tackle at least 4 out of the 6 ones. So, intellectual disabilities, autism spectrum, ADHD, and specific learning disorder, which are, of course, very common and also relevant in the practice of psychology here. So, what are the intellectual disabilities, or what are intellectual disabilities? So, intellectual disabilities are neurodevelopmental disorders characterized by significantly impaired intellectual and adaptive functioning. So, it is defined by an intelligence quotient or IQ score below 70, in addition to deficits in 2 or more adaptive behaviors that affect individuals' everyday life. It is well known, or it was known before as mental retardation until the end of the 20th century. However, this term is now widely seen as disparaging, so the intellectual disability is preferred by advocates and researchers in most English-speaking countries. So in addition, while the definition of intellectual disability once focused almost entirely on the cognitive ability, it now also addresses both mental functioning and functional skills. As a result, a person with unusually low IQ may not necessarily be considered intellectually disabled. So, what are some key points regarding intellectual disability? Firstly, intellectual disability is characterized by an intelligence quotient below 70 as well as deficits in 2 or more adaptive behaviors that affect everyday life. So, not only that there is the cognitive function side, but also there is the adaptive function side. So, both are measured. The cognitive function side is measured through IQ test. Meanwhile, the adaptive behavior side, there is also a scale for that to measure. Okay? So, these characteristics become apparent in childhood or in adolescence. Intellectual disability can either be syndromic, meaning the intellectual deficits are associated with other medical and behavioral signs and symptoms, or non-syndromic. The intellectual deficits appear without any other abnormalities. So, among children, 30 to 50% of intellectual disabilities are of unknown cause. Genetics, events during pregnancy, and environmental factors are all thought to be possible contributors. And currently, there is no cure for an intellectual disability. However, with appropriate support and teaching, many individuals can learn to live fulfilling, productive lives. So that's why, back to our first definition of disorder versus illness. So that's why I emphasize that I prefer the term disorder rather than illness. It's because illness implies that there is a cure, meaning once that the cure is there, it will be permanently gone. Meanwhile, disorder, so it involves our functioning because there is a disorder disordered functioning. So it involves recalibrating our minds and also our behavior so that we can go back to the normal order of our functioning. So, and like I said, neurodevelopmental disorders, these are from childhood. So, meaning the onset is from childhood. So, this is the DSM criteria for intellectual disability or intellectual developmental disorder. So, intellectual disability or intellectual developmental disorder is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. The following three criteria must be met. A. Deficit in intellectual functions such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience confirmed by both clinical assessment and individualized standardized intelligence testing. Deficits in adaptive functioning that also results in failure to meet developmental and socio-cultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social participation, and independent living, across multiple environments such as home, school, work, and community. And also, the onset of intellectual and adaptive deficits are during the developmental period. Okay? So, in the DSM, I think there is a table for the severity when it comes to the adaptive functioning and intellectual functioning. So, better check on that so that you can further study what are the different severity symptoms for you so that you can help those who have intellectual disability to recognize that the child may have intellectual disability. So, another intellectual disabilities is the global developmental delay. So, it is previously known as in the DSM-4 as mental retardation severity unspecified. The term global developmental delay or GDD in DSM is used to explain developmental disability in children who are under the age of 5. It refers to an important developmental milestone delay in regards to motor, speech, and language, cognition, social functioning, and activities of daily living. So, GDD is seen about in 15% of children below the age of 5. So, GDD is seen as a temporary diagnosis for children who are unable to undergo standardized IQ evaluation because in some testing, some IQ tests do not include or their product do not include children below the age of 5 or they have a separate scale for children below the age of 5 and children in the preschool age. Some children are diagnosed under a year of age while others become evident when the parents compare their children to others of the same age. Delays can show up as multiple issues and end in diverse prognosis with children. This can be hard to pinpoint as the actual determinants are very variable. This classification can be labeled as prenatal, perinatal, and postnatal. They range from genetic abnormalities such as syndromes and anomalies to hypoischemic encephalopathy to central nervous system infections. So, before we go into the diagnostic criteria for global developmental delay, let's look into how do we diagnose someone with GDD. So, there are multiple tests used in the diagnosis of global developmental delay. This consists of the following below. Genetic, molecular, and metabolic tests. These are tests that are usually conducted via urine or blood samples and are able to detect hereditary types of global developmental delay. In addition, blood and urine tests also allow for evaluation of abnormalities in body chemistry which can contribute to developmental delay. In children born to mothers with a history of alcoholism, tests can be conducted to check for fetal alcohol syndrome. So, another is chromosome testing. These tests help in inherited problems and genetic defects that can contribute to global developmental delay. Some specific genetic testing can be done to evaluate certain rare disorders. One of the most common genetic causes of GDD is Fragile X, and conducting this test can eliminate the possible cause. Rett syndrome is high-ranking cause of GDD among girls. The screening of girls for Rett syndrome can be beneficial in eliminating this possibility of GDD. The third one is through neuroimaging test. So the third one is through neuroimaging tests, such as CT and MRI can be conducted to evaluate any possible injury to the central nervous system and the brain. By looking at these detailed images, doctors can be provided insight regarding some children with GDD, while MRI offers a more detailed images. CT brain scans are faster to do and much cheaper for patients. So let's now go on to the diagnostic criteria for global developmental delay. So this diagnosis is reserved for individuals under the age of 5 when the clinical severity level cannot be reliably assessed during early childhood. This category is diagnosed when an individual fails to meet expected developmental milestones in several areas of intellectual functioning and applies to individuals who are unable to undergo systematic assessment of intellectual functioning, including children who are too young to participate in standardized testing. This category requires reassessment after a period of time. So this global developmental delay can be served as provisional diagnosis for children who are under the age of 5. So that's why also, if you are interested with handling children or to become a developmental psychologist, so review your developmental psychology subject, review what are the different important developmental milestones when it comes to children, especially from birth or even before birth up until they are 5 years old or in their preschool age. Okay, so I hope that my students will also have an interest with regards to developmental psychology, because we are also in need of those psychologists. We also in need of psychologists who are specialized in that area. Let's now go into the autism spectrum disorder. So this is also one of the common neurodevelopmental disorders here in the Philippines. What is autism spectrum disorder? ASD describes a range of conditions classified as neurodevelopmental disorders in the 5th Division of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. This is redefined as the autism spectrum to encompass the previous DSM-4-TR diagnosis of autism, Asperger's syndrome, and pervasive developmental disorder not otherwise specified, and childhood disintegrative disorder. These disorders are characterized by social deficits and communication difficulties, repetitive behaviors and interests, sensory issues, and in some cases, cognitive delays. So ASDs are considered to be on a spectrum because each individual with ASD expresses the disorder uniquely and has varying degrees of functionality. So what are some key points with regards to ASD or autism spectrum disorder? So ASD is formerly referred to as autism. It is a disorder of neural development characterized by a broad spectrum of social communication and behavior symptoms as evident in early childhood. ASD is considered to exist along a spectrum because each individual with ASD expresses the disorder uniquely and has varying degrees of functionality. Social impairments in childhood with ASD can be characterized by a distinct lack of intuition about others. Infants with ASD show less attention to social stimuli and smile and look at others less often. Children with ASD may exhibit repetitive or restricted behavior and self-injurious behaviors. So this repetitive or restricted behaviors can be, for example, stereotypies, which is repetitive movement, compulsive behavior, sameness, or resistant to change, restricted behavior or limit in or focus interest or activity, and self-injurious behaviors. So ASD affects information processing in the brain by altering how the nerve cells and synapses connect and organize. How or why this occurs is not well understood, but it is thought that ASD has a strong genetic basis. So, the main goal when it comes to treating children with ASD are to lessen associated deficits and family distress, and to increase the quality of life and functional independence. The most widely used therapy is applied behavioral analysis or ABA. So now let's look into the diagnostic criteria for autism spectrum disorder. So just to take note, it is now called autism spectrum disorder. So regardless whether the diagnosis is Asperger's syndrome, autism, or pervasive developmental disorder, so it is now still recognized as autism spectrum disorder. So letter A, persistent deficits in social communication and social interactions across multiple contexts as manifested by the following: currently or by history. So examples are illustrative and not exhaustive. So number one, deficits in social emotional reciprocity, ranging, for example, abnormal social approach and failure of normal back and forth conversation, to reduce sharing of social interests, emotions, or affect, to failure to initiate or respond to social interactions. So number two, deficits in nonverbal communicative behaviors used for social interaction, ranging, for example, poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures to a lack of facial expressions and nonverbal communication. And number three, deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties in adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or making friends, or to absence in interest in peers. So, of course, severity is based on social communication impairments and restricted repetitive patterns of behavior. And there is also a specified table for that. So, just read your DSM-5 in order for you to further differentiate. If you notice, the number one key symptom here is impaired or deficit in social communications. So it is somehow a communication disorder, social communication disorder, and you can see this in children who in their infancy or during their toddlerhood, they are unable to respond or reciprocate social emotional feelings, or they are also unable to non-verbal and verbally communicate to their parents. So in letter B, there is also a restricted repetitive behavior of interests or activities as manifested by at least two of the following: currently or by history. So examples are illustrative and not exhaustive. So number one, stereotype or repetitive behavior or movements, use of objects or speech, for example, simple motor stereotypies, lining up toys or flipping objects, echolalia, idiosyncratic phrases. Number two, insistence of sameness, inflexible adherence to routines or ritualized patterns of verbal and or nonverbal behaviors. For example, extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to take some root or eat same food every day. Number three, highly restricted, fixated interests that are abnormal in intensity or focus, or for example, strong attachment to or preoccupation with unusual objects, excessive circumscribed or perseverative interest. And number four, hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So for example, apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. So as you can see, there is also restricted repetitive patterns of behavior or interest or activities in people with autism. So they have a different way of functioning. They have their own unique way of functioning. And of course, this list are just examples, and it may vary to children who are diagnosed with ASD. So symptoms must be present in the early developmental period, but they may not fully manifest until social demands exceed limited capacities or may be masked by learned strategies later in life. Letter D, symptoms cause clinically significant impairment, social, occupational, or other important areas of functionings. And of course, they are not better explained by an intellectual disability or global developmental delay, and intellectual disability and autism spectrum frequently co-occur to make comorbid diagnosis of autism spectrum disorder and intellectual disability. Social communication should be below that expected for general developmental level. So, in here, we have specifiers. So, with or without accompanying intellectual impairment, with or without accompanying language impairment, associated with a known medical or genetic condition or environmental factor, associated with another neurodevelopmental, mental, or behavior disorder, and with catatonia. So, I think Jubilee channel has a video regarding people with ASD. I want you to watch that. So, it's a very interesting video. So, they look into whether do people with ASD think similarly or what are their differences. So, as you can see, ASD still has little research about the causes, about the what specifically is the difference. There is little research about the causes and also what makes the person with ASD different from other normal people. So it's important to also look into that if that's your passion, especially in developmental psychology. I also encourage you to research about ASD. So these are some disorders that are rare but it would be nice if it is studied more so that people can produce treatment and therapy, more effective therapy for people with ASD. So they have a very unique way of really functioning and thinking that we as normal people, sometimes we cannot understand them. So there are some people with ASD who are gifted, especially in a certain area. So you can also look it up in the internet and be amazed that some of them even paint the whole New York City only once by memory. So he only saw the sky in the area of New York. I think it's New York via helicopter, and he memorized it and he painted it exactly. So they have a very unique thinking. So I encourage you in the future that to research more about these disorders and how unique one person functions really. Next is attention deficit hyperactivity disorder. So attention deficit hyperactivity disorder, it is a neurodevelopmental psychiatric disorder characterized by constant pattern of inattention and or hyperactive and impulsive behavior that interferes with normal functioning. So the first person to describe a version of ADHD was physician Heinrich Hofmann in 1920s. So the first official recognition of the disorder was attention deficit disorder with and without hyperactivity in the DSM-3 published in 1980. Revisions to the DSM eventually renamed the disorder as attention deficit hyperactivity disorder. Despite being the most commonly studied and diagnosed psychiatric disorder in children and adolescents, the cause in the majority of cases is still unknown. So the World Health Organization estimate that it affected about 39 million people as of 2013. It affected about 6 to 7% of children when diagnosed using their earlier DSM-4 criteria. So the incidence is about 3 times higher in boys than in girls. And approximately 30 to 50% of children diagnosed with ADHD continue to experience symptoms in adolescents and adults. Many children with ADHD are unable to pay attention at school, leading to poor academic performance and sometimes isolation from peers. So, what are some key points with regards to attention deficit hyperactivity disorder? So a child with ADHD shows a constant pattern of inattention and or hyperactive and impulsive behavior that interferes with normal functioning. The DSM-5 indicates three subtypes of ADHD. Number 1, ADHD predominantly inattentive type. Number 2, ADHD predominantly hyperactive impulsive type. And number 3, ADHD combined type. General symptoms of ADHD include impulsivity, forgetfulness, inability to concentrate, impatience, thrill-seeking, excessive daydreaming, restlessness, and unusual or disruptive sleep patterns. So, the cause of ADHD is still unknown, but most researchers agree that it is an interaction between genetic and environmental factors. While there is no known cure for ADHD, there are several treatment approaches that can manage symptoms. ADHD management usually involves some combination of therapy, medication, and deliberate lifestyle change. What is the diagnostic criteria now for ADHD? So, number A persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development as characterized by 1 and or 2. Number 1, inattention. 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. So note, the symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or failure to understand tasks or instructions. For older adolescents and adults, at least 5 symptoms are required. A, often fails to give close attention to details or make careless mistakes at school, at work, or during other activities. For example, overlooks or misses details or work is inaccurate. Letter B, often has difficulty sustaining attention in task or play activities. For example, has difficulty remaining focused during lectures, conversations, or lengthy reading. Letter C, often does not seem to listen when spoken to directly. For example, mind seems to be elsewhere even in the absence of any obvious distraction. Letter D, often does not follow through instructions and fails to finish work, chores, duties in the workspace. For example, starts tasks but quickly loses focus and gets easily sidetracked. Letter E, often has difficulty organizing tasks and activities. For example, difficulty managing sequential tasks, difficulty keeping materials and belongings in order, messy, disorganized work, has poor time management, fails to meet deadlines. Letter F, often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. For example, schoolwork or homework. For older adolescents and adults, preparing reports, completing forms, reviewing lengthy papers. Often loses things necessarily for tasks or activities. For example, school materials, pencils, books, tools, wallet, keys, paperwork, eyeglasses, mobile telephones, and is often easily distracted by extraneous stimuli. For older adolescents and adults, it may include unrelated thoughts. It's often forgetful in daily activities, for example, doing chores, running errands. For older adolescents and adults, returning calls, paying bills, keeping appointments. And number 2 is, of course, the hyperactivity and impulsivity. 6 or more of the following symptoms have been persisted for at least 6 months to a degree that is inconsistent with developmental level and negatively impacts directly on social and academic occupational activities. Note that symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or a failure to understand tasks or situations. So, letter A, often fidgets or taps hands or feet or squirms in seat, often leaves seat in situation when remaining seated is expected. For example, leaves his or her place in the classroom, in the office, or other workplace, or in other situations that require remaining in place. Often runs about or climbs in situations where it is inappropriate. Note, in adolescents or adults, may be limited to feeling restless. D is unable to play or engage in leisure activities quietly. So is often on the go, acting as if driven by a motor. For example, is unable to be uncomfortable or being still for an extended time, as in restaurants, meetings, may be experienced by others as being restless or difficult to keep up with. often talks excessively, often blurts out an answer before a question has been completed. So, for example, completes people sentences, cannot wait for turn in conversation, has often difficulty in waiting his or her turn, for example, while waiting in line. Often interrupts or intrudes in others, so butts into conversations, games, or activities, may start using people's things without asking or receiving permission. For adolescents and adults may intrude into or take over what others are doing. So what is important also here is the letter B's criteria. So several inattentive or hyperactive impulse symptoms were present prior to the age of 12 years, and several inattentive or hyperactive impulse symptoms are present in two or more settings, for example, at home, school, work with friends or relatives, and in other activities. Also, there is a clear evidence that symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And symptoms do not occur exclusively during the course of schizophrenia or other psychotic disorder and are not better explained by another mental disorder. So, I have already mentioned the specifiers: combined, predominantly inattentive, and predominantly hyperactive or impulsive. So, just remember the difference between ADHD and the normal being naughty or playful of a child is that first is, of course, it is not only limited to a certain situation or one situation, and it's not only exclusive to one incident. So it's recurrent, it's persistent, and it's in two or more different settings. So usually at home and at school, or at home or at play, or at home at social gathering or church, for example. And of course, it severely impacts the functioning of the child. It means that the child, for example, during at school cannot finish his or her homework, or cannot pay attention to the lecture, or even disrupts the lecture because the disruption is very beyond the normal level of being naughty or being playful. So that's the difference between ADHD and the normal playfulness or being naughty or being quote unquote hyperactive of a child that is normal. So last disorder in the neurodevelopmental stage is the specific learning disorder. So what are specific learning disorders? So this is a classification of disorders in which a person has difficulty learning in a typical manner within one of several domains. It is often referred to as learning disabilities. Learning disorders are characterized by inadequate development of specific academic language and speech skills. So these types of learning disorders include difficulties in reading, mathematics, and in writing. So what are the key points of specific learning disorders? So specific learning disorder is a classification of disorders in which a person has a difficulty learning in a typical manner within one of the several domains. The causes of learning disabilities and learning disorders are characterized by inadequate development of specific academic language and speech skills. So the types of learning disorder includes difficulties with reading or dyslexia, mathematics, dyscalculia, and writing dysgraphia. So the causes of learning disabilities, learning disorders are characterized by inadequate development of specific language and speech skills. And depending on the type of severity of the disability, interventions and technology may be used to help the individual learn strategies that will foster future success. So here is the diagnostic criteria for specific learning disorder. So A, difficulties in learning and using academic skills as indicated by the presence of at least one of the following symptoms that have persisted for at least 6 months despite the provision of interventions that target those difficulties. Number 1, inaccurate or slow and effortful word reading. For example, reads single words aloud incorrectly or slowly and hesitantly, frequently guesses words, and has difficulty sounding out words. Number 2, difficulty understanding the meaning of what is read. For example, may read text accurately but do not understand the sequence, relationship, interferences, or deeper meanings of what is read. Number 3, difficulties with spelling. May add, omit, or substitute vowel or consonants. Number 4, difficulties with written expression. Makes multiple grammatical punctuation errors with sentences, employ poor paragraph organization, written expression of ideas, lacks clarity. Difficulty mastering number sense, number facts, or calculation. For example, has poor understanding of numbers, their magnitude and relationships, counts on fingers to add single-digit numbers instead of recalling the math fact as peers do. Number 6, difficulties with mathematical reasoning. For example, has severe difficulty in applying mathematical concepts, facts, or procedures to solve quantitative problems. So letter B, the affected academic skills are substantially and quantifiably below those expected for the individual's chronological age and cause significant interference with academic or occupational performance or with activities of daily living as confirmed by individually administered standardized achievement measures and comprehensive clinical assessment. For individuals aged 17 years and older, a documented history of impairing learning difficulties may be substituted for standardized assessment. Letter C, the learning difficulties begin during school-age years but may not become fully manifested until the demands for those affected academic skills exceed the individual's limited capacities. For example, as in time tests, reading or writing lengthy complex reports for a tight deadline, and excessively heavy academic loads. Letter D, the learning difficulties are not better accounted for by intellectual disabilities, uncorrected visual or auditory acuity, or other mental or neurological disorders, psychosocial adversity, lack of proficiency in the language of academic instruction, or inadequate educational instruction. So note, the 4 diagnostic criteria are to be met based on the clinical synthesis of the individual's history, both developmental, medical, family, educational, school reports, and psychoeducational assessment. So, what are the different types of specific learning disorders? So, the first one is dyslexia, so sometimes called reading disorder. It is the most common learning disability of all students with specific learning disabilities. 70 to 80% have deficits in reading. The term developmental dyslexia is often used as a catch-all term, but researchers assert that dyslexia is just one of the several types of reading disabilities. A reading disability can affect any part of the reading process, including word recognition, word decoding, reading speed, prosody, or oral reading with expression, and reading comprehension. So dyscalculia is a form of math-related disability that involves difficulties with learning math-related concepts, memorizing math-related facts, organizing numbers, and understanding how problems are organized in the page. Dyscalculics are often referred to as having poor number sense. And lastly, dysgraphia. Dysgraphia is often used as an overarching term for all disorders of written expression. Individuals with dysgraphia typically show multiple writing-related deficiencies such as grammatical and punctuation errors within sentences, poor paragraph organization, multiple spelling errors, and excessively poor penmanship. So in dysgraphia, it is often characterized by grammatical and spelling errors within sentences, poor paragraph organization, multiple spelling errors, and excessively poor penmanship. I think that's all of the disorders. So that is the last. And I hope you really learned a lot about mental disorders, about the signs and symptoms of different mental disorders. And I hope through these video lectures, I have provided you a quality course, a quality subject here, so that you can still remember it even until or after you graduate. So I really hope that you have learned a lot, and I hope that I have provided you the necessary information for you to start in learning more about this. And I hope someday in the future, you will become mental health professionals or mental health advocates even. So I hope this video has been very helpful for you, and God bless everyone. God bless in your journey as third year. So next time we will be talking about assessment already, and I hope that in our time during abnormal psychology, you have learned the importance of assessment, and you have learned that to recognize different signs and symptoms, especially the behavioral observations. So goodbye everyone, and see you on the next SEM for our psychological assessment series. So I hope that we're still well and good, and I hope someday we can all meet face to face. So bye bye. Goodbye everyone.